So thank you very much again, and we'll also like to open it up at the end for questions. So we'll maybe go us three, and then we'll just have general questions. So I'm on behalf of Dr. Stratakis, I'm going to talk a bit about the NIH programs and the patient, and I'm not going to talk about the patient perspective. So again, this is the hospital where we work in beautiful Bethesda, Maryland. And you all may know something about the National Institutes of Health. Anybody feel like you know what it is? I always like to find out. Yeah, one person. We're really sad about that because we're funded by the taxpayers' dollars. We're the largest clinical research hospital in the world, and yet nobody knows about us. So, but now after today with Dr. Stratakis, you will all know about this because you will not forget what he tells you. So. I'm going to tell you a little bit about the NIH first. So the mission of the NIH, this is congressionally funded and mandated. And our mission per the Congress is to uncover new knowledge that will lead to better health by conducting research in its own laboratories, which is what we call the intramural program. That's the hospital I showed you. That's on a larger campus with, I don't even remember how many people we have, 8,000 or something like that. A lot of people in the intramural programs. And then the NIH also funds other research. So it provides support, meaning dollars, for research conducted by scientists in universities, medical schools, hospitals, and other research institutions, primarily in the United States, but also abroad. And we refer to that as the extramural part of the NIH. And a third part of our mandate is to train research investigators, so to train physician scientists, PhD scientists, and others who will go on and do what, carry it forward in perpetuity. And another thing we're supposed to be doing, and we're both here today on official duty, and we're supposed to communicate medical information. So this is part of our mission as well. We do that both by speaking at conferences, but also by publishing what we have discovered and giving interviews and things of that sort. So I'm going to now turn to just intramural, because you want to know how to get into an intramural NIH program, and some of our other speakers I know are also funded through the extramural dollars. But now just to turn to intramural, these are the 27 or so institutes and centers of the NIH, and the ones that have pink names are the ones who have investigators who are involved in Cushing syndrome programs. And one of the things that's really great is that we have collaborators in these various institutes who have other skills that we don't have, like we're not radiologists, but we have fantastic radiology collaborators and others. So our research at the NIH, we're the two main endocrinologists who are doing this work at the NIH. You've got an idea from what we said that we have separate protocols. Constantine's a pediatrician and geneticist, so he sees the lifespan of people, but sees pediatric cases. I don't, because I'm not a pediatrician. We have really great support for surgery. So endocrine surgeons in our place are the ones who do belly surgery and neck surgery. And so they're going to be taking out the malignant thyroid cancers that make ACTH, the adrenal tumors that cause Cushing syndrome, the pancreatic neuroendocrine tumors. We have neurosurgeons who take care of our pituitary cases, and thoracic surgeons who do the ectopic tumors in the chest. We've got really good interventionalists who do inferior pituitary sinus sampling. That, by the way, was basically codified at the NIH about, I don't know, too long ago to remember, but 35 years or so. And we have investigational radiologists, so we have access to PET studies that are not available elsewhere or not widely available elsewhere. We have a rare tumor clinic with a double-boarded endocrinologist and oncologist who's very interested in the intersection of those issues. And we've got access to some unusual resources, not unique, but unusual. So I do FDOPA and dotatate PET scanning, was doing that before dotatate became available in the United States. We have metabolic chambers and hoods to look into energy expenditure in Cushing syndrome. Our nurses can do frequent blood sampling every 10 minutes, once an hour, that kind of thing. That can be very helpful in really difficult cases. And since our mission is to conduct research, we're supposed to be doing research, so we're allowed to do research. We would be held unaccountable, or we would be told we were not doing what we're supposed to be doing if all we did was just purely see patients. So we are all salaried, and so we don't have any numbers of patients we have to see in a half-a-day clinic or in a full-day clinic. And that's why both of us can spend this. We have this luxury of time to spend with our patients, so we really get a deep understanding of the patient experience and understand the patient's history and other things of that sort. And as I mentioned, it's funded by the taxpayer, so there's no charge to patients to be at the NIH. Various institutes have different policies in terms of paying for patient travel, but once you're there, there's no insurance that's taken, no money that's taken, it's just free. But to get in, you have to fit some sort of protocol, and a protocol can be a natural history study where we're just looking at the natural history, we're just doing standard clinical care, or a protocol can be interventional or hypothesis-driven study, but either way, you've got to fit into some protocol that will study what it is you have. So we don't study every single medical disorder known to man or unknown to man. We only study specific things, and so you got to fit. So that means that not everybody can be accepted into a protocol, but most of the time there's some Cushing's protocol that you might fit into, so there's hope. So how do you enter a Cushing syndrome study at the NIH? Generally, and I think Constantine will speak for himself if this is different for him, but I think both of us ask that people have their physician send a referral letter to an investigator, so that'd be one of us or a research contact, with the stuff related to the reason why you want to come. So something about your history, your physical examination, laboratory results. Different protocols have different requirements for how much of that is necessary to screen a patient. And then the person who looks at your information will evaluate whether you fit the protocol. And we often go back and forth between us. If there's somebody comes in with an adrenal cause, for example, a PPNAD, that I don't spend more than 5 minutes looking at that. It goes right over, actually not across the table, it goes down the hallway to one of Constantine's people to look at. So we try to maximize the patient's ability to get into studies and maximize each of our abilities to see patients for our studies. And then once it looks like you may be eligible, you usually get some sort of feedback in terms of what you're going to have to do, because it's a two-way street, right? You have to fit our protocol, but then you have to be able to come and do the things we want for our patients. And sometimes this may be quite a few visits. It may be only one visit. It may not fit what you're looking for. And so then you get to decide whether or not you want to come. And that's all I'm going to talk about. We're going to open it up to questions afterwards so that you can get more out of us if we haven't explained enough. So, Amy. Sure.
Hello, my name is Amy Dom. Thank you, Dr. Niemann, Dr. Stratakis. I'm absolutely thrilled to be here today. If, as I was telling my boyfriend, if you had told me 5 years ago when I was flat on my back, recovering from surgery with my little leg massagers, worrying that I would be appearing on stage with the man who saved my life, I could not have imagined it. So thank you, Dr. Stratakis. Just briefly, the NIH is outside, for those who are wondering, Bethesda, Maryland is right outside of Washington, D.C. But even for those people who live in Washington, D.C., NIH is a huge enigma. There are 5,000 labs there. And I can say as a former member of the State Department that there was more security getting into NIH than there was getting into the U.S. Department of State. So these are some of my NIH milestones. I wanted to talk about my life pre-Cushing's, my diagnosis, and then my discovery of NIH, the assessment that I went to, the testing and treatment that I underwent in January of 2014, my post-op care, which I say welcome to adrenal insufficiency, my 1-year post-op reality check. That was my very unpleasant come to Jesus conversation with Dr. Stratakis. Waking up what my friends refer to as sleeping beauty. That was my right adrenal gland. And then my recovery, and then the impact that being a patient at NIH had on me personally. So before Cushing's, I was a glamorous international woman of mystery. I was a foreign service officer in the U.S. State Department. I had a degree from Wharton. I had an MBA from there. And I had been a staffer to the Secretary of State, Secretary Clinton. I had worked in the Operations Center at the State Department. And then I had briefed the spokesperson before each daily brief on U.S. policy positions regarding Russia and Ukraine. Yes, very pertinent these days, isn't it? Yeah. Too bad we're no longer having daily briefs. But anyway, yes. So in terms of the diagnoses, in October of 2012, my Cushing's journey started fairly innocuously. I went into my gynecologist, and it was October 2012. He called me back into his office. I was terrified. I was like, oh my God, I waited too long for my PAP. But no, he said, you have high cholesterol. You really need to get this checked. And I said, well, okay. So I kind of brushed it to the side. I'm like, everyone has high cholesterol, whatever. But then every time I turned around, something else seemed to be wrong. I couldn't open a jar of pickles. I could barely walk to my briefings. I would be briefing my principal, and I would use the wrong word. I called it Mad Libs. I'd kind of trail off in the middle of a sentence. I was just like, what is going on? I mean, it just seemed like my body was slowly collapsing, and no one could give me any answers. And I really do applaud my medical team, my internist, Dr. Max O'Shalom, my cardiologist, Dr. Ross, and then my neurologist, Dr. Podalicchio, because they really did, they were with me every step of the way, and they were with me until I got answers. And they coached me about how to talk to my other doctors. So it's extremely important that you build up your own medical A-team to get you through this. This is not for the faint of heart. You need the big leagues. So I went to literally dozens of specialists, and it just seemed that people were treating the symptoms, but no one was putting together the whole puzzle. And that's until Dr. Mark Sklar in September of 2013 in Washington, D.C., he luckily had interned, or had been a fellow, I think, at NIH, and he ran the full battery of tests, and he finally said the only thing left is Cushing's. So my official diagnosis after we did the imaging was adrenal Cushing's. So then my boyfriend and I went down to breakfast, and I was just kind of like, well, where do you go when no one knows about your disease? Like, they literally don't even know what it is. They've never seen anyone who's had it. So, of course, the answer is NIH. But my rule of thumb that I kind of followed, in addition to just gut instinct, was go someplace with a high number of Cushing's patients. Nothing replaces frequency of interaction with actual Cushing's patients themselves. So before diagnosis, Dr. Sklar had made these kind of vague threats and references about, quote, referring me to NIH. And I'm like, I don't even know what that means. But I did hear it twice in a week, and I was like, well, maybe I really need to look more carefully at this. So I sent off letters to several different institutions, and the ones that seemed to click best were Mayo, so I went up there with, and NIH. So I went up and I scheduled a second opinion at Mayo with Dr. Todd Nippolt. He is an adrenal specialist. I made sure not to get an endocrinologist who specialized in diabetes. I wanted someone who specialized in adrenals and thyroid. And I think it's extremely important to really ask for what you need in this process. And so my mom went as a note taker because by this point I was extremely foggy, and there are still points and elements of conversation that my mom will bring up that I don't remember. I mean, so it really is important that you have someone to help be there for you emotionally, to help support you, and also just concretely to take notes and be a second set of ears. So in November of 2013, I met for my assessment, and I met with Dr. Stratakis, Dr. Zilberman, and Bobby, who is also a doctor, for 2 hours. And it was absolutely marvelous because I felt like they were hanging on to my every word. They wanted to know everything about this condition and what my symptoms were. And, there were points where I felt like I had been fighting for my doctor's attention. And here I felt like they were really giving me their true, focused attention and really wanted to get to the bottom of what was going on. It was a huge relief. Oh, and so you can see this is a picture right around the time I was diagnosed with my friend John. So you saw the first picture, and now you see this one. I mean, there's clearly a very different, there's a huge difference physically. So in terms of testing, so basically I was accepted into the protocol, and things moved very quickly after that. I mean, in November I had my assessment. By January, I went in for 10 days of testing and assessments at 5 Northwest, which is the Cushing's wing. There's like a whole wing dedicated to Cushing's patients at NIH in Bethesda. And I arrived on a Sunday night, and it was kind of like night at the museum. It was like there was no one around, and it was like this huge building, and I was just like, oh my God, what have I gotten myself into? But luckily, everything worked out well. The nurses were extremely welcoming. And it literally, for the first time, I felt like I could relax because I was in the right place. I was in a place where people knew my illness, they were world experts at treating it, and this was going to be my best shot of getting treated anywhere. So also beforehand, I had received a testing schedule from Bobby, who is Dr. Stratakis' right-hand guy. And it almost looked like I kind of went into it thinking, I'm going to treat this like a European medical spa. Like, I'm gonna, all different like tests and everything, but I want to be like extremely comfortable. So I brought pajamas, and I brought my coffee machine. Not everyone can do that. I brought my different comforter, and like slippers and flip flops. So I wanted to be as comfortable as possible because it was going to be an extended stay. So there are also I was surprised that there was such a holistic approach at such a scientific institution. Basically, NIH looks at mind, body, and soul together, mind, body, and spirit, which I was extremely surprised by. I mentioned that I wanted to get some reflexology treatments outside of NIH, and my doctor was like, oh, well, why don't we just schedule you for massage and acupuncture with our world-famous acupuncturist, Dr. G? And I was like, that sounds amazing. So I was extremely impressed with the real attention to the whole person. And one of the most helpful people I interacted with was Monsignor Dominic, who was the chaplain. And he himself has an illness, and so he really got it. And I had lots of questions, as Dr. Stratakis alluded to. I'm a very questioning person, and I felt I literally had a list of them on my little board at my room, and he went through and answered every one. So that was good too. So after extensive testing, it was decided I have adrenal cyclical Cushing's. And 2 tests were used to determine that. I know there's a lot of questions within the community about, how do you test for cyclical? So in my particular case, 2 of the tests that were most definitive, and I'm sure Dr. Stratakis can elaborate on this, is the hair test, which Dr. Zilberman, I believe, was doing a hair study. And that shows basically it's almost like kind of a tree where you see like the cortisol spikes within the hair itself. It's which is extraordinary over the lifetime of whatever's captured in the hair. And then a diurnal cortisol test where the cortisol is measured. And in the case of cyclical Cushing's patients, a lot of them have a flat cortisol profile. So it's the same throughout. So like a lot of Cushies have a reverse diurnal rhythm. Like a lot of cyclical Cushing's patients have a flat profile. They have the same number. So in terms of treatment, January 15th, 2014, I checked back in for surgery. So I checked out after my testing. I had a week to kind of have fun. And then I checked back in to my old room. And Dr. Stratakis did ask me to mention he does treat both adults and children. So it was kind of interesting that there were lots of different types of people in 5 Northwest. Various therapies, quote, on the inside. That's how people within NIH refer to like things inside the building or on the inside. That kind of made me giggle. I was like, it sounds almost like prison, but it's not. It's on the inside. And then everything else is on the outside. So there, again, a holistic approach. Dr. Stratakis is extremely tough on his fellows, and he makes sure that his patient, which I kind of delighted in personally, but he makes sure that all of his patients get the best of everything that NIH has to offer, which is terrific. So we had occupational and vocational therapy, rehabilitation, dietitian, psychiatric evaluation, speech pathology. I mean, really addressing like every aspect of what Cushing's can impact. So Dr. Naris Nillable and a fellow performed my unilateral adrenalectomy. They removed my diseased left adrenal gland and tumor. And it was a little touch and go. I was having trouble with oxygen saturation, so thank God I had brought my CPAP. I think it may have literally saved my life, because as soon as I put the CPAP on, I was able to breathe more easily, and I spent a night in the ICU. One of the benefits of being at NIH is that you receive like the highest standards of care. So in terms of what has been definitively proven through research, you have access to it. And I didn't understand the significance of that until I talked to other people who had been in surgery elsewhere. And of course, they received good treatment, but maybe they didn't know about the leg massagers, or their doctors are hesitating to prescribe an injection. And these are just kind of a matter of course at NIH. So after surgery, I woke up and I saw this medical bracelet lying neatly on the side of my bed, and I was thinking, well, what's this? And this was welcome to adrenal insufficiency. So I basically traded in a disease where I would die slowly and painfully for a disease where I might die quickly and painlessly. So that was like extremely, that was very difficult to kind of digest. And I was very happy that I had people there to help me kind of get through that. In terms of the care, there were leg massagers to help prevent blood clots. Those are important. There was a little breathing apparatus that we had to do in order before I would be discharged. I had to learn how to inject the orange. My endocriner sat down, and because I didn't get it the first time, she had to sit down with me 2 or 3 times in order for me to understand how to actually self-inject and where. The sick day rules protocol, I would learn how to appropriately dose for all sorts of different medical emergencies, and also for emotional ones too. And emergency injection kit. And also, over the course of time, I learned that alcohol and caffeine were my friends when I had adrenal insufficiency. So basically, over the course of the next year, I kept working, although I had working more like part-time, but I still had, I had to maintain my steroids in order to keep functioning. And then I went in like 1 year post-op, and I had my come to Jesus with Dr. Stratakis, and he literally told me I was actually going to get more serious, quote unquote, about my recovery and dropping my hydrocortisone more quickly. And that was extremely, that was really bracing. It was a huge wake-up call. So I went on medical leave from the Hill Fellowship that I had been doing, and from the State Department, and to focus on my health, and to really be able to take the drops and make the rests and do what I needed to do that was necessary to get better. I figured I only had 1 shot, and I was going to take it. So in terms of waking up Sleeping Beauty, in January 2016, after 2 years, I learned at Mayo that basically most adrenal patients, their adrenal gland wakes up somewhere between like 9 months and 18 months, or 2 years. So it's kind of on the tail end of that, although it is known to have happened later as well. After 2 years, my right adrenal gland woke up. I was extremely excited, and my ACTH stemmed to 18. And so I was technically, safe. And but then it took me another 5 or 6 months to wean off of this daily steroids. It was extremely difficult for me. And Dr. Stratakis had advised me to seek counseling. That talk therapy really helped, like the emotional process of weaning, and it really did. It was my touchstone and my anchor. And so, going to weekly therapy and having that routine, I was able to wean off of daily steroids completely by May 2016. And he did warn me, and this is something that I've heard, but I haven't seen a whole lot of mention of, is that he warned me to follow the sick day protocols for at least a year after, like, completely weaning off of daily steroids. And that's because it takes your brain at least a year to loop in. So, in terms of recovery, I medically retired from the State Department in 2017. I prioritized my health, and I was lucky I was in the position where I could, and so I did. And I now volunteer as a patient advocate. I write articles, I appear on a podcast and radio, I lobby Congress for additional funding for Congress. I continue to research the illness and try to help others. And then I pursue avocations. I like to travel, I like to do genealogy, writing, and I help harassment victims at state. But the good news is that you don't have to actually even be a patient at NIH to take advantage of the resources there. And you don't have to be in a protocol. The NIH library is one of the best in the world. Anyone in the world can come and use it for free. And that's where I personally researched my information and my articles for medical retirement. So it's extremely valuable. In terms of the rare disease, there's a rare disease hotline where literally the American taxpayers are paying people at NIH to research your questions. So if you need a referral to a doctor, if you need an endocrinologist, if you have a question about Cushing's, you can call them up and for free, they will research this information for you. It's an invaluable resource. I actually used it for a friend of mine. I used it to research some information on his behalf. There's also a fairly newly established NIH Rare Tumor Center. And then there are the NIH protocols. So in terms of impact, I mentioned this before, NIH taught me the standards and best practices for my illness. It introduced me to CSRF. One of the nurses mentioned, hey, there's this newsletter floating around. You should check it out. I think you'd really enjoy it. I think it'd be really helpful. And she was right. I mean, and I've become increasingly involved with CSRF. My time at NIH has formed the foundation of my advocacy. A lot of my cushy colleagues have gone through NIH, but also when I go ask for money for Congress, it's for NIH, for all rare diseases, and for and I tell my story about a Cushing's and adrenal insufficiency, and I think it's very important for us to get our stories out there in a wide variety, and we need as many advocates as possible and as many faces as possible to do that. It taught me the importance of being the captain of my own ship and researching. This is one of these rare diseases where you can't rely on the doctors to always tell you what to do. You're gonna have to make some of your own judgment calls, and you're gonna have to be extremely informed, because there is a point, I'm not saying with Dr. Stratakis or Dr. Neiman, but where you may know more than your doctor. And it's important to keep track of the latest information and to be as knowledgeable as possible. And also, I just feel like it brought me back to myself. Because of the resources at NIH and because of the approach and the relationships I had there with people who really cared about me, I was able, now I can open my jar of pickles, now I can volunteer, I can walk, I can stand for more than 2 minutes and not get too fatigued. So, my recovery has not been linear by any stretch, but it has been mine. And, there has been an upward trend. And for that, I am extremely grateful. So thank you very much. And that's my little buddy, Sam, who's been with me every step of the way. Yes, did you have a question? I was very naughty. I was 22. I was at 22.5, and I was a year out. So, and he's like, I'm not going to stim you again until you're at 10. I said, okay. So, it worked. Any other questions?
Yeah,
I believe
so I mean, so there's several sites you can go to. So first of all, if you go to the clinical center site, there is the number for the patient recruitment office to call, and they can direct you from there. But also, you can go to the clinicaltrials.gov site that lists all our protocols there. And for every protocol, there is a point of contact or a person of contact. So a name was mentioned, Babis, whatever, my assistant. So we are listed as my name and all my people as persons of contact for our protocols. And Lynette has Raven, was absolutely wonderful too. So that's the way to get in, and it's true for all the protocols that are run at the NIH. And elsewhere. And I also want to say, thank you, Lynette. I want to point out that, I mean, first of all, we are a federal facility. We did not pay Amy to say any of that, okay?
No. Believe me, these words are all mine. Yes.
And we, the point, I think, of the whole presentation was that, as it is true for any rare disease, patients need to go, and doctors need to encourage this, to the centers, the places, the hospitals that have the specific programs around the disease. Whether it is, most of the hospitals have research around the diseases that they study, but it doesn't have to be research. The point is that the place has to be specialized. Today, okay, trivia. I like trivia. How many diseases there are out there? Genetic diseases. 7,000. How many diagnoses are out there in the code system, in the ICD, that uses the Medicare and Medicaid use? How many diagnoses are out there? Do you know? 72,000. How many medical procedures, codes for medical procedures are out there? 69,000. 69,000 procedures, 72,000 diagnoses, 7,000 genetic diseases. How many drugs has the FDA approved so far? About 7,000, 8,000. So give me a human being, a doctor, who has finished Harvard. He's at Harvard, all Harvard. Can he know all 69,000? Can he know all the drugs, all the 8,000 drugs? No. Doesn't matter how smart you are, how good you are. For every disease, for every one of these 7,000 genetic diseases, for every one of the 69,000 medical procedures, there is a specialist. There are more than 400,000 physicians in the United States. Each one of us specializes. That's what we know. And doctors need to know, and patients need to know, what questions to ask to make sure that they are seen by the specialist. So at the NIH, we happen to have a more than 30-year history of studying Cushing's and adrenal diseases and pituitary diseases. And so I was trained there by Lynette and others, and we've become good at what we do. But that's all we know. I mean, if you come to me for gallbladder surgery, you don't want to see me. It's gallstones, for God's sake. He needs to know. I mean, who doesn't know about gallstones? No. You need to go to somebody who deals with gallstones all the time.
So just to amplify on that, I think one of the reasons why we've been successful, and I should add that all the people who are talking this in this conference are all experts. Leslie did a great job of culling out some people who are really great in their field, and so you're going to get to hear from, it's not just the NIH that's good at this. Everybody, anyone who's up here talking, it would be great for you to see them. But one of the reasons I think why we've been as successful is that right from the very beginning, when this started in 1981 and 82, we recognized that we needed great radiology support, we needed great surgical support, and we needed endocrine support. And when people talk to me about what I've done or what anybody's done, Constantine or any of us endocrinologists say, we're not here by ourselves. We only got there because we have these other people. So you need not only great endocrinologists who are studying whatever the disease is, but you need to know that they're going to refer you to a surgeon who's had so much experience with that kind of surgery that you're going to minimize complications and maximize their ability to handle any weirdness that comes up during the surgery. And likewise, you're going to go to an interventional radiologist for petrosal sinus sampling who knows how to do it, who knows what to do when there's little tiny little vessels, and how do you interpret it, and all of that sort of stuff. So it's not just the endocrinologist, but it's all of the support staff as well. And so we're really lucky to have it all in one place. And I think the centers of excellence that I guess we're going to be hearing about next, I think that's going to be a recurring theme. You need to get everybody, if not in one place, at least in a referral pattern.
And for the, we should say something about the surgical expertise. Obviously, I do think that in Cushing's in particular, diagnostics is extraordinarily important. But but surgical expertise is perhaps most important. So I always tell my patients, because we have to, at the NIH, when you come and see us, we say, and that's what doctors do at every center of excellence for any disease, you have the option to go elsewhere. And I give them the option to go to places that I know are good at what they do. But then I tell them, like, for example, if they tell me, I give the option, for example, to go to Mayo Clinic. That's just an example that was mentioned. But when you go to Mayo, you need to go to the doctor or the surgeon that is doing the things that you are being seen for. So the first question you're going to ask to the neurosurgeon is, okay, how many pituitary surgeries have you done this year? On average, a neurosurgeon, a general neurosurgeon, at even an academic center, is doing 7 to 8 pituitary surgeries a year. Why? Because most neurosurgeries, skull trauma, spine, they don't do pituitary surgeries. So you don't want to go there. This is going to be the head of neurosurgery at the biggest academic center in your state. He's a wonderful, absolutely outstanding neurosurgeon, except that he does 7 to 8 pituitary surgeries a year. You don't want to go there. You don't want to go there. Where would you go? To the pituitary neurosurgeon, who is doing more than 30, 20 pituitary surgeries a year? You want to go to somebody who has done 100 or more pituitary surgeries recently in the last 5 years. Now, our numbers at the NIH right now is probably around 40 pituitary surgeries, 40 to 50 pituitary surgeries a year. NIH as a center has done more than 1,500 pituitary surgeries in the last almost 30 years. And it may be more if you count some of the surgeries done in the 80s. Huh? Yeah, so that's the questions. The same thing is for the adrenal. You'll ask, just say one more thing about the general surgeon. So wonderful surgeons out there. Abdominal surgery is done routinely, right? But the chief of surgery at the best academic center in your state has done probably no more than 20 adrenal surgeries a year. That's not enough, especially when the surgery is going to be done laparoscopically, especially when the surgeon has to recognize what may be cancer. Fortunately, it's very rare. Only 1 in 1,500 tumors of the adrenal cortex are cancers. But what if the surgeon misses that one and spills over the cancer cells when he does laparoscopic removal of an adrenocortical adenoma? You don't want that to happen.
Thank you. And also, I want to say NIH is not the answer for everyone. I have several friends who are Cushing's patients. I have extreme respect for their journeys and for what they've experienced. And, sometimes it's not a match, and that's okay. Every person has their own set of criteria, and, you have to do what's best for you. Of course, I'm extremely pro-NIH. They saved my life. But again, it's not always the answer. But it is a path forward, and I think that people should be aware of that, especially since this is like a financially devastating illness. And to have these sets of resources available to us, we are extremely fortunate.
Questions, yes.
I have a different question from one of the comments that you made about the brain after you're weaned off the hydrocortisone. Is that for pituitary also?
Yeah, so the recovery of Cushing's, whether it is pituitary Cushing's or adrenal Cushing's, depends on the brain, because it is all based on the ACTH levels. Now, when you have an ACTH producing tumor, typically the brain is not as suppressed, so it takes a little bit shorter time, on average about 12 months to recover. When you have an adrenal tumor, the suppression tends to be longer, and the numbers are typically, of cortisol levels are typically higher. And so the recovery of the brain ACTH, or the pituitary ACTH, takes longer. As Amy said, the average about 18 months, sometimes 24 months. There's also a few patients, and I think we increasingly see these cases. I was in a meeting last week in France where we reviewed cases of Cushing's, adrenal Cushing's, and Lynette, you may have seen these cases where the other adrenal never completely woke up. And there's not good explanation of why this happens. I'm sure there is people in this room that may have experience with something like this. They're rare, fortunately, but there are a few cases. There's cases that took 5 years from adrenal Cushing's to recover, and there's a few cases that took forever, or it never really happened, or at least not at its fullest. There's no good explanation for that. Well, over-replacement is the obvious. That's just why I made her suffer.
For good cause. Yes.
I have a question. You were talking about when you stem at 18.
Yes.
When you do that, you stem at 18.
Mhm.
But what if you don't stem quite at 18? What if you stem at 17.4, 17.4, you're almost there? So are you considered you don't need to stem?
No. The numbers. You talk to the patient. So it's all about how the patient feels, what the needs are, what the schedule is at work. There's a lot of factors. I mean, there might be a patient that will stem at 14 and I may not continue with replacement. There might be a patient that will stem at 19 and I may say, well, I think you need 5 milligrams of hydrocortisone in the morning. So it really depends. Lynette may have something to say about it.
Yeah, I think the other thing to realize is that this number of 18 is not magic. The cutoff point for a successful stimulation varies from 17.5 to 22.5 over the last 20 or so years of people reporting on this. And that's probably because cortisol assays, one to the next, are different. If you take my blood and put it in 10 different assays, you're going to get 10 different numbers. And so each center, when they come up with their cutoff point, is reflecting their assay. So that's part of what we're saying, that our assay may be different than somebody else's assay. We're comfortable at 17 by saying it's fine. The whole stimulation and when you get off and all that, we could have a whole conversation about that. For example, I don't stim at a certain number. I look at baseline cortisols. I don't taper, like Eliza was saying earlier. I don't taper, I stop, because I use a very conservative replacement that's based on body surface area. Other people don't do that. I mean, we all have very different, nuanced, subtle ways that are slightly different, one of us to the next. And we all feel very strongly that that's the right way, but there's no data under most of this. It's just our experience and what seems to work for our patients. I'm really concerned about people taking too much cortisol and never getting off, and so I'm very conservative. But other people worry more about how the patient's feeling. And yeah, give me 10 milligrams of cortisol, and I'm gonna feel better, I'll tell you. It's a great drug, but it's not good for you long term.
Remember, I made the point, and that cortisol secretion in normal people is episodic. Okay, remember, and remember what I told you when I was finishing up, that at midnight, remember what I said? What is the cortisol level at midnight? Nothing, 0 for a normal person, for non-stressed, sleeping well at their time zone. 0%.
0% of the population fits into this criteria.
Actually, and you look at kids, right? So you look at toddlers that sleep well, are not stressed, and I have done these studies, and so they have 0 cortisol at midnight. But of course, they're not stressed; they're living their own world, and just their parents. And so it's also amazing when you look at the diagnosing Cushing's in kids under 18 versus adults. So Lynette did the study for the adults and showed that if you want to be certain that somebody has Cushing's, the midnight cortisol level has to be over 7.5 micrograms per deciliter, okay? And she did that by looking at all the numbers of all the adult patients with Cushing's we've had over numbers of years. I did the same study in kids. What number was the same cutoff? I mean, I used exactly the same criteria that Lynette had for the adults, 4.4. And how do you explain that difference? Every single kid that had a midnight cortisol level below 18 years of age, over 4.4, had Cushing's. But in order to be an adult and be certain, Lynette's, I think, numbers were like 100%, that you had Cushing's, You had to have a midnight cortisol level over 7.5. So what happens? What happens? Well, I know what happens. You go to college. You stay out late. You get on drugs. You do things. You know? What happens? What do all these things do to your? What do these things do to your brain, to your hypothalamus? What they do is they disturb the normal hypothalamic regulation of cortisol secretion. You want another example? When you grow older, you look at the elderly over the age of 70. Look at midnight cortisol levels and ACTH levels at the elderly. Nobody has an undetectable cortisol level over 70. ACTH levels more than double as you cross into the 8th decade of life. Why is all of that? Because the normal hypothalamic pituitary adrenal axis loses its nimbleness, if you want. It's a nimble axis. It's extraordinarily sensitive. Let me tell you one final thing so that you remember that. There's no other hormone in the body except for melatonin. There's no other hormone in the body that has a 20-fold or higher difference between the number that you have in cortisol levels when you wake up in the morning versus the 0 or so, 1.8, that you have at midnight. More than 25 micrograms per deciliter at 7:30, 8 a.m., less than 1.8 at midnight. There's almost a 20-fold difference between midnight and morning cortisol levels. There's no other hormone in the body like that. There's no other hormone that has that exquisite diurnal variation, which is why we use diurnal variation as a diagnostic test, because it is the first thing that is disturbed in Cushing's.
At cortisone, and it's still up to your medical dosing or stress dosing if needed. So since then, have you had to still do that after that 1 year was passed?
You know, I have. Extremely rare. I'd say maybe a handful of times, 5 times. One time I got in a bad fight with a friend, and then I had a conference, and I could tell I had low cortisol symptoms. And one time I was ill, but it's been literally a handful. I'd say maybe 4 or 5 at the most. But I knew, like I felt the familiar symptoms, and it wasn't like a full medical dose. It was maybe 2.5 or 5 or 10. And that was it, but I could tell that I was, getting the familiar heaviness and the kind of lethargy, and yeah, so. Did it? Ooh.
Sadly, I'm sitting next to a pediatric nurse, and I told her, I think this may be an adrenal insufficiency issue. She didn't care.
Oh, that's horrible.
I was able to get like 2 pills under my lip, and now I'm totally different. But
Well,
it was a rough
yeah,
hour today.
yeah, I believe it.
I needed about a month ago, so.
Oh, man.
So for
Well,
a year, we should plan.
Yep. Your steroid injection with you. I had 3 or 4 of them, kits, like at my boyfriend's, at my house, at work, in my purse. And yeah, just take every precaution, because I think this is actually kind of a dangerous, where you're entering is a dangerous point because you get kind of cocky. Yep. Yeah, exactly. And keep hydrated on the flight. That's extremely important too. Okay.
But I think you also need to recognize that people, as I said earlier, different people are different. And I was trying to count up how many patients, but I've probably had about 1,200 people that I've counseled about AI after surgery. And I can count on my fingers and my toes the number of people who actually went into a crisis. So I think that if you're really careful, so that's very few crises for a lot of patients. And I think part of it is that we really drum into people about the stress dosing. When do you take stress dosing? Stress is not for all emotional stress, or we would all be taking hydrocortisone every single day. But when physically do you take it? I have marathoners who I give a stress dose to before they run. But it's usually for it's a diagnosis of the flu or vomiting or diarrhea or something like that. I think if you're careful with the stress dosing, you can really avoid the crisis. And it only comes on in situations like this where you probably changed your time zones possibly, or your time frames, or when you took things and stuff like that. So, so folks, don't think that you're going to be going into crisis 10 times a year. It's not going to happen if you're careful about the stress dosing and if you're on a good replacement dose. Are we on time?
5 minutes.
5 minutes.
More about stress dosing. So are you, and I asked this because I'm due for a dental implant, so I asked my endocrinologist if I could get some steroids so I could take it before the dental implant, and he said, you don't need that anymore, Cushing's is over, you're all.
So how far out? Yeah, so you probably don't need it. But what we do when we do stress dose for operations or preoperative dosing, extra dosing, like Dr. Straka said, we really modulate that according to the severity of or Dr. Gear, somebody said it. We modulate it according to the severity of the operation. So if you're going to have cardiac bypass surgery, you're going to get a lot of hydrocortisone. If you're going to have a dental implant or dental cleaning or dental extraction or things like that, that's on the really low end. And for those, I just have people take double their morning dose of their oral med right before the procedure. But so if you were taking steroids, that's when we double. Or for the first year after, if you had to have surgery. Although there are no data to suggest that that needs to be done. And there are really lovely data from the old days when we used to use opiate anesthesia, and that will reduce your steroid levels to 0. So in England, when they did cardiac bypass surgery with opiate anesthesia and you had absolutely no steroid on board, those people did absolutely just fine. And there are a lot of data showing that you really don't need to give stress doses during surgery. So I think some of this is fear. Some of it is that we all feel better with extra hydrocortisone, up to a certain point. And some of it is that there are some patients that really, truly do crash. And it may be that those are more the people with adrenal forms where they are needing adrenal insufficiency from an adrenal problem, intrinsic adrenal problem, and not the Cushing's adrenal insufficiency. Because if you have no ability to make mineralocorticoid, the Florinef piece, you're going to crash a lot easier. So I think we also conflate primary adrenal insufficiency with post-operative adrenal insufficiency, and we take the one thing that we've learned in the one place and put it on the other one where maybe it's not necessary. So in part, what I'm trying to get across is that we don't know all the answers to all the questions, and maybe we'll never know all the answers to all the questions, and that's one reason why you hear so many different answers, because it hasn't always been studied well, and there are opposing views that have some merit for a lot of these things. So.
There's also a lot of variability in each one of us on how we absorb, how we metabolize hydrocortisone or cortisol, and how much cortisol we have in the blood at any given time also depends on medications we take. Lynette just mentioned the effect of opioids on the whole cortisol secretion, but there are a number of medications that we all take frequently, and they affect metabolism, for example. And so a lot of patients that are on what one would consider proper dose of replacement may still go into adrenocortical insufficiency if people don't think of the interactions. I'll give you one example that often happens in pediatric patients. So we have patients with Cushing disease that get operated, and because they don't grow very well, we give them growth hormone. Well, when we give growth hormone to a person, we suppress endogenous cortisol production. So 30% of your cortisol is lost when somebody goes on growth hormone. Is that amazing? So, and many pediatricians don't know that. So when they start the kid on growth hormone, they have to increase the dose of replacement for hydrocortisone by 30%. But people don't do that, and then kids go into adrenal insufficiency. Just giving you an example from the endocrine world, but there's a lot of other medications out there that affect cortisol metabolism, from opioids to other medications that affect liver function and so on. Yeah, in extreme cases, hyperthyroidism, for example, affects cortisol levels. Hypothyroidism similarly, but in the range that we usually deal with, free thyroxine of 0.8 to 1.4, there shouldn't be huge variability in cortisol metabolism. But below that or over that, yes. Growth hormone suppresses cortisol production. If you take for replacement because you don't have adrenals anymore, and you at the same time start growth hormone, you need a 20 to 30% increase of your dose. I'm not saying it is, but it is the general rule of increasing the dose by 20 to 30%.
Hello. Just making sure this microphone works. My question is for Dr. Lehman and Dr. Protocols. I'm a Cushing disease patient with one reoccurrence, one in 2013. In 2018, I was 18 months post-op thinking it was finally safe for me to finally replace about 7 teeth with dental implants. I went through 4 surgeries this summer. I have 1 remaining. And my cortisol level is usually around, it's been measured at 9 post-recovery from the second surgery when I'm tested. I cannot believe the amount of pain that I feel when the oral surgeon is putting the Novocaine in my mouth. I don't take any hydrocortisone. I was totally weaned about 5 months post-surgery in 2018. I don't understand that level of pain that I have when I think I scare my oral surgeon each time because tears will flood out of my eyes with the pain that I'm experiencing. I take no hydrocortisone. My cortisol is normal, maybe low normal these days, but I have never understood why I have this immense pain still in my jaw every time that they administer Novocaine to me. And I don't know if that's that rush with the adrenaline and the cortisol and everything else, but it's an extremely painful operation. I have one again in another 2 weeks, and I'm not looking forward to it. But do you have any idea why I might be experiencing this this far into post-surgery and recovery?
Hard to know if it's just when they put the lidocaine in underneath near the nerve. It's not when they actually are doing a procedure? Yeah. So have different pain thresholds, so you're saying that this is different than what you used to be?
Yes. I don't experience that level of pain where I'm not crying, tears are just flooding out of my eyes, so the pain is extreme.
Yeah, this is not one that I've heard from people. My colleagues might, we're going to end of the session, so maybe somebody else has heard that. I must say, though, that every time I hear something I haven't heard before, I start asking my next patient about it, because a lot of times there are these little, I don't know, it just hasn't come up before types of things, and so I'm going to start asking people. Maybe we'll hear if other people have increased. I do think that for some patients the pain threshold goes down, but I haven't heard somebody say, I only have it when I have something with my teeth. I've heard that my whole body feels pain more, but I haven't heard just the jaw injection thing yet.
My whole body does feel more pain, but nothing like what happens.
And I don't know what the medical reason for that would be, but I can say, at least from a perspective, I've heard of this before from other people, and I don't have a good reason for it. Sorry. I would say it's much less common now than it has been before. One of the advances in this area was the understanding that you can use MRI monitoring of the pituitary gland and ACTH levels, and that the ACTH levels at the time of adrenalectomy predict or can help to predict who may develop Nelson syndrome. So I think it's much less common than it used to be, and I think that the jury is still out on whether prophylactic radiation therapy is helpful.
It's what I was thinking when you were asking me the question. I was thinking about the possibility of Nelson syndrome in your case. Yeah. So as Lynette said, then if you look at the numbers that were published 20 years ago or so, they say 30 to 40% of the patients would be at risk for developing Nelson's if you do adrenalectomy in a patient with a previously existing STH-producing tumor. But the real numbers seem to be this more recent data because of the increased detection of these tumors and cure of pituitary tumors. The real number seems to be more like 10 to 15%. So it's much lower. Yeah, much lower. Remember that, in essence, no patient develops Nelson's unless there is a pre-existing ACTH-producing pituitary tumor. Only when the adrenals get removed in a patient that has a pre-existing pituitary tumor, Nelson's develops. The old fear that when you take the adrenals in a patient that has normal pituitary, there was going to be an ACTH-producing tumor developing, it just hasn't been proven true. It may happen, but it just hasn't been seen. So a few ACTH were never really truly removed from the tumor in the pituitary, and so that's how it came back. Question?